Section 18, let us go through disorders of the adrenal gland. And so the session overview, disorders of the adrenal gland are discussed, including Cushing's syndrome, Addison's disease, and then other ones that are not so common. And then the pathophysiology of these conditions are also well noted. And so at the end of the session, the students should be able to apply their previous knowledge in anatomy and then physiology to explain the pathophysiology of conditions associated with the adrenal gland, and then recognize possible manifestations such as those that are related to abnormalities of these organs, and then identify predisposing factors related to these conditions, and then render appropriate nursing care to patients with these conditions. So first we'll look at Cushing's syndrome, and the opposite is Addison. So the key topics to be covered here in the session are as follows. Now let us look at the Cushing's syndrome. I want you to look at specifically the revise your previous knowledge and look at the adrenal gland, and then other names and where it is situated, and then functions of the adrenal gland. So adrenal gland is also known as suprarenal gland, and then adrenal paired glands located on the top of the kidneys. So each of these of the adrenal glands has two parts. You remember that from your anatomy and physiology. You have the adrenal medulla, which is the inner part, and then outer part is the adrenal cortex, and the two functions are separate endocrine glands. And so we have the medulla, and then we have the adrenal cortex. And adrenal cortex releases steroid hormones, and 3 classes of steroid hormones are secreted by the cortex. And these are glucocorticoids. We have the mineralocorticoids, and then we have the androgens and estrogens, and these are the sex hormones. So glucocorticoids, the major glucocorticoid is cortisol, and the cortisol is a prototype of hydrocortisone, which raises blood sugar levels by reducing glucose utilization, and it may also do that by promoting glucose formation from protein and then fat gluconeogenesis, among so many functions. And then cortisol also suppresses the inflammatory processes, reactions at multiple sites in our body. And you have functions for mineralocorticoids, and they regulate electrolyte and then water balance by promoting absorption of sodium and then the secretion of potassium by the renal tubules. An example is aldosterone, and the major hormone of this class. And then it acts mainly on the kidneys, but it can affect other organs in the body. And later you can take your time and then go through this. And then androgens too, we have small quantities of these which are produced for sexual development and growth. And then androgens required by both sexes for normal pubertal and then skeletal development. Now, with the Cushing's syndrome, we refer to a chronic disorder in which hyperfunction of the adrenal cortex produces excessive amount of circulating cortisol. In other words, this condition results from high levels of cortisol or other corticosteroids in the circulation, and is associated with various changes in the body, including the development of obesity. It can also lead to hypertension. We have diabetes, and then we have osteoporosis. It is relatively rare and most commonly affects people from 20 to 50. And the Cushing's syndrome occurs when the body's tissues are exposed to excessive levels of cortisol, which I've already explained. And many people suffer the symptoms of Cushing's syndrome because they take glucocorticoid hormones such as prednisolone for asthma, rheumatoid arthritis, and then also for inflammatory diseases. And so the prolonged use of or abuse, especially by women, for other reasons such as cosmetic reasons or factors of oral or topical corticosteroids such as prednisolone, metazone, hydrocortisone, or cortisone, and or preparations containing any of these drugs is also a major cause. Especially our women, they may say that they want to put on weight, and so they may be taking prednisolone and other things. And so when one continues to take some of these drugs, what happens is that you are increasing the cortisol level in circulation. So others develop Cushing syndrome because of overproduction of cortisol by the body. So normally, the production of cortisol follows a precise chain of events. So first, the hypothalamus, a part of the brain, which is about the size of a small sugar cube, sends corticotropin releasing hormone, which is CRH2, the pituitary gland. And the CH causes the pituitary gland to secrete ACTH, which is the adenocorticotropin, a hormone that stimulates the adrenal glands. When the adrenals, which are located just above the kidneys, receive the ACTH, they also respond by releasing cortisol into the blood circulation. And so cortisol performs vital tasks in the body, and then it reduces the immune system inflammatory response and then other functions. So when the amount of cortisol in the blood is adequate, the hypothalamus and the pituitary release less CRH and then ACTH. And as we have already noted, this may ensure that the amount of cortisol released by the adrenal glands is precisely balanced to meet the body's daily needs. However, if something goes wrong with the adrenals or their regulating switches in the pituitary gland or the hypothalamus, cortisol production can go awry, and its production will happen in a way not actually planned for. And so as you can see on the screen, we have Cushing syndrome. And so we have Cushing syndrome. Picture showing a lady with the abdomen, and then we have a lot of fats in those areas. And classification, disorder may be classified or grouped or categorized as primary, secondary, or iatrogenic, depending on the etiologic origin. And so primary Cushing syndrome is the result of benign or malignant adrenal tumor that causes an increased production of cortisol. And the secondary Cushing syndrome is the result of one of the following conditions: a pituitary or hypothalamic disorder, which may cause increased release of ACTH, and this disorder is called Cushing's disease. And so Cushing's disease refers to one specific cause, namely adenoma in the pituitary gland, that actually may produce large amounts of ACTH, which in turn elevates blood cortisol levels. We also have an ectopic disorder that produces ACTH, for example, bronchogenic carcinoma or malignant neoplasm of the lungs, in which case it causes over 50% of these cases. And then we can also have pancreatic carcinoma. This disorder is called ectopic Cushing syndrome. In either case, the increased ACTH stimulation results in hyperplasia of the adrenal cortex with increased cortisol production, which is the main factor that we are looking at. And then in some cases, we can also have iatrogenic Cushing syndrome, which is the result of long-term corticoid therapy, for instance, excess cortisol levels. For instance, clients who take steroids over a long period of time, for example, the treatment of arthritis after an organ transplant or as an adjunct to chemotherapy, are at increased risk for the development of iatrogenic form of the disorder. And so the most common iatrogenic Cushing's may be due to physicians or the doctor's treatment, where the patient is put on cortisol for a very long period of time. So now, with this background, as we have identified the types, primary, secondary, and the other iatrogenic types, in many instances we can look at the clinical manifestations coming from the point of view of the fact that here, anywhere that we have considered, we are looking at the increased level of cortisol in circulation. So in many instances, patients may be treated for the secondary metabolic dysfunction such as diabetes mellitus before diagnosis of Cushing's syndrome is actually considered, because the manifestations point to the fact that cortisol levels may also increase the sugar level of an individual. So increased hepatic gluconeogenesis and then impaired insulin utilization results in postprandial hyperglycemia in individuals, and occasionally frank diabetes mellitus with all manifestations can be seen. And so patients with concurrent diabetes mellitus may experience worsening hypoglycemia. So you can imagine if somebody has hand in hand with what we call the diabetes at the same time with Cushing's syndrome, then it means that once the cortisol level goes up and the sugar level goes, it means that that patient with diabetes with associated Cushing's is rather going to suffer and then get a lot of complications because of the hyperglycemia. So cortisol raises blood sugar levels by reducing glucose utilization and also by promoting glucose formation from protein and then fat. In other words, cortisol counteracts insulin, contributing to hyperglycemia in individuals who may be affected by a stimulus of hepatic gluconeogenesis and then inhibiting utilization of glucose. Again, in many instances, patients may be treated for hypertension before a diagnosis of Cushing's syndrome is considered. So hypertension occurs as sodium and water are retained at the distal tubule of the nephron due to excessive aldosterone production. So sodium and water retention may accentuate body weight and then increase and may cause edema and may also expand blood volume. So in actual sense, hypertension is found in almost every patient with excessive cortisol and may be caused by increased volume and then increased sensitivity of arterioles to circulating catecholamines. And this is exactly what we see in these people. So catecholamines in this sense are hormones made by adrenal glands, and they are released into blood circulation during time of physical activity or emotional stress, and they are norepinephrine or epinephrine. And so we have altered protein metabolism, we have proximal muscle wasting, and then we have depletion of protein matrices, and then loss of collagen support of skin, and then resulting in thin, fragile skin, and then bruises easily, and then purple striae may also be found, and then poor and then slow wound healing and infection is also likely to occur in these individuals. And then we have altered fat metabolism, and so changes in fat metabolism increases the person's chances of getting other conditions. And so we can have buffalo hump over the upper back and then around the areas around the face, and so we have moon face, and then we have redistribution of fat with these characteristic features may be seen in patients without overt obesity, and body weight is usually increased in the affected individuals, and we have alterations in inflammatory and the immune response, and so they can get infection at any point in time, and excessive androgenic activity. So if excessive androgens are present, female patients show other male characteristics. We can think about excessive facial hair in particular, manifested mainly initially as fine drowsy coat of hair on the face and body. We have changes in menstrual cycle, and then men have decreased fertility with diminished or absent desire for sex, and the children tend to be obese with slowed growth rate. And then we can also have hyperpigmentation of the skin and mucous membranes. Complications: hyperglycemia, hypertension, hypernatremia, and then hypokalemia. We have to read on these complications. Diagnosis is through physical examination and then variety of tests, including serum measurement of cortisol levels and the urine test for cortisol, and then the most important initial diagnosis test is in the patient with suspected Cushing syndrome is confirmation of excess glucocorticoid production, and that is very important. Physical appearance is also important, and then the following laboratory tests may also be considered. Measurement of plasma cortisol levels is also very important, and the normal levels may be done at 8 a.m. And then early in the morning, and that will be between 6 to 23 micrograms per deciliter, and the higher results may indicate or suggest adrenal tumor, Cushing syndrome, ectopic ACTH producing tumor, and then pituitary Cushing's or Cushing's disease. And the lower than normal level will mean Addison's disease or hypopituitarism. And the measurement of ACTH levels also to determine the etiologic origin of the syndrome is also very, very important. And then a 24-hour urine test can also be done to measure free cortisol and the androgens, and these hormones are increased in Cushing syndrome. And then other tests can also be done. And the diagnosis of this syndrome includes an increase in serum sodium and then blood glucose levels, and then decreased concentration of potassium, and the disappearance of lymphoid tissue, and then scar film, chest x-ray, CT scan are also used to localize tumors in suspected organs, including the pituitary. Treatment modalities include surgery, irradiation, and then pharmacologic therapy, or a combination of these three approaches are very, very important. One, pharmacologic therapies are used often in combination with irradiation. So the Nurs have provided adrenal enzymes inhibitors are also important, and then surgical treatment may also be used to remove the pituitary gland. And then if it's indicated when Cushing syndrome is the result of a pituitary disorder, so the gland is removed either by transsphenoidal route and then or by craniotomy. So you can read over these ones, and the surgery will provide further news. And the nursing care is very important, and we need to consider fluid volume excess, and then you need also to monitor blood pressure, teach the client and the family the reasons for restricting fluid, and then importance of limiting fluid if ordered by the doctor, and the risk for injury. Infection prevention is also very important, and then we need to also look at that and then prevent it in individuals who may be affected. Body image disturbances, we need to look at that because of the structure, a lot of pus in the abdominal area, and then the back, and then other parts of the body, as we have already noted. We need to look at client and then family education, requires education about self-care at home specific to the type of treatment given, and then discharge planning also focuses on preparations towards discharge, and that is big when the patient is admitted. Addison's disease is opposite of Cushing's, and so I've provided the notes. You can go through the types: primary adrenal sufficiency, you have the secondary adrenal sufficiency, and then causes, as you can see, clinical manifestations. The notes are there. So take your time, go through, and then with diagnosis also provided, and then the tests that you need to do, as well as other diagnostic procedures that may suggest the condition that has occurred, and you have to also look at the treatment based on the treatment objectives, and then also consider non-pharmacological treatment and then pharmacological management, and also complications that are treated. For instance, Addisonian crisis, where the BP goes down drastically, and then how to manage it, and then nursing management in general. The Nurs is pointing to all this, especially under the. So in summary, we have looked at the Cushing syndrome, we have looked at the Addison's condition, and your reading assignment is on Addisonianism and then pheochromocytoma, and then you have the references provided for further readings. Okay.